Good afternoon. I realize that I'm one of the speakers after lunch, so I will try to make this as entertaining as I possibly can. I have a couple fun graphics, and there will be a quiz at the end. Just kidding. Just a little about CPEN. We are the California Pan-Ethnic Health Network. We're a little over 20 years old, about 23 years old, and we were really founded in an era of health reform in the mid-90s, founded by 4 ethnic partners who came together that felt that communities of color alone, or the different ethnic partners on their own, needed to come together to really provide a unified voice around health reform. And here we are, 23 years later, really engaged in the implementation of the Affordable Care Act. And also not just improving access to health care, but also ensuring that we have the data to be able to inform the decisions about where resources go, the types of information that we are providing here at the roundtable and supporting our efforts. Also looking at the provision of culturally and linguistically appropriate healthcare services, and also looking at the communities around us, really addressing some of those social determinants of health that we talked about earlier that also impact people's health. So just a quick overview. I'm going to breeze through the first 5 slides. Promise you won't be quizzed on those. Just to give you a context of why this is really important, I have 3 models that I want to talk about how we've both looked at legislative and administrative advocacy to promote change, and also some concluding thoughts. So California's, has one of the most diverse populations within the nation, and that's really reflected in both our Medi-Cal program in terms of language and ethnicity. So almost a third of Medi-Cal enrollees are limited English proficient. If you add them all together, California's covered California population is almost 60% communities of color, and the top 5 languages within covered California: Spanish, Chinese, Korean, and Vietnamese. We also know that language has been an impairment to finding usual source of care and also finding specialty care, primary care, and that as a result, typically individuals with limited English proficiency tend to rate their health as being poor or fair overall compared to their English-speaking counterparts. So all of these, just to kind of provide the case is how we've been advocating for the importance of language assistance standards in California, and to show you a couple of the models that we're going to talk about today. So there we have, both in our public program and in our commercial program, we have language assistance standards. So we have threshold standards, which is, again, the requirement, thanks to the brilliant presentation this morning. The provision of written information is based on, in Medi-Cal, you see the numbers here, and then in the commercial side of plans, so if you get your health care through your employer, for example, they're based on some enrollment numbers. I'm happy to break those down a little later. They're slightly more complicated. For interpretation services, any language, in the Medi-Cal program, it's any time of day. It is a requirement. On the commercial side, it's typically been limited to business hours, which has been a little challenging. But again, also covering any language. Also within the commercial plans, the original legislation that was set up requires the collection of race, ethnicity, and language data. So going to Jessica's point about making sure, incentivizing this to happen, healthcare plans on the commercial side are required to collect that data. However, there is some flexibility, and so they can also impute some of the ethnic breakdown, racial and ethnic breakdown based on census data. So this is something that, again, we're trying to overcome with plans, making sure that they're building that in their systems rather than just continuing to use the commercial data. The other important factor that I want to mention too is that we've incorporated these within the reporting and compliance standards. So plans were required to provide a report to the Department of Managed Healthcare. In addition, the DMHC goes and actually surveys the plans to make sure that they are actually providing these services. So some key opportunities. We didn't just arrive here overnight. Obviously, it took quite a bit of work and several years to be able to get here. But one of the things that we had going in our favor is that within public programs, we already had some of these standards in place. So with 3.4 million LEP enrollees in private coverage, we were able then to make the case that rather than just letting the market decide, that we should have some standards in place about how plans were going to provide their language assistance services. We also had the benefit of at that time that there was a new department that had great, strong leadership on these issues. And so we were able to move the department as well. Through, again, legislative leadership, we were able to pass SB 853, which is the commercial side of plans. Recently, we've been able to codify the Medi-Cal managed care thresholds. So for many years, since the mid-90s, they've been in contract language, and now they're actually in statute. So providing a little bit more leverage there for us to enforce. The unfortunate side, so we talk about how hard it is to actually integrate language assistance, cultural competency, and health literacy. There were no health literacy standards. There were very little health literacy standards that were involved in SB 853. All of the culturally competent provisions were taken out of the bill through negotiations, through a very difficult negotiation process. The new Department of DMHC, who came on a couple years after when we were actually implementing the legislation, was not quite as consumer friendly as the original director was. And we, again, exempted public programs from all of this, which, again, just goes to the fragmentation of the system. We can't align everything together. So this is one of the visuals I promised. So this is a Covered California application form that, if you see, it's all marked up with red. So one of the things that we were able to do through this rapid response coalition that we've been a part of for the past 7 years, 8 years actually, is we were able to get advanced copies of the application, of several notices and other things, where our community-based organizations, partners who actually work with these communities every day, were able to review the application and provide some guidance. So a couple of the things that they found, and this just kind of talks about, we've looked at the Medi-Cal and Covered California populations, we've worked on marketing to communities of color, and we continue to do these ongoing assessments. So a couple of in doing this review that the community-based organizations provided, they found, first of all, that the Hmong translation was completely inaccurate. They had found, that was the picture that you saw, and it goes on for another 20 or so pages where there's just red mark after red mark where there was not a very good application form done. In Tagalog, for example, one of the community reviewers found that the term marketplace was something that was very difficult to translate into Tagalog. And because Spanish also is similar, they share some similarities, I think that was also a problem there. In Vietnamese, things like family size, lawful residency, really key important components of what kind of coverage you're going to be eligible for, were also not very accurate. That there was very formal language that was used, it was very rigid, there was too much text. So those were the kinds of examples, and so based on some of the review, we were able to get changes to the application form and continue to provide some incentives or some information around the notices that both the Department of Healthcare Services and Covered California provide. So just the key opportunities were really that we have these, again, this broad coalition that we work with that has been engaged in California policy for several years with us, that were able and nimble to collect the information and then return it. They provided some credibility, they were very thorough, they were very responsive to the departments, and so building that relationship over time, they continue to come back to us and rely on us. We were there with the founding of Covered California, so we got in at the very beginning and really kind of introduced ourselves, talked about what the importance was, and that is reflected in the leadership today. We have diverse partnerships that also help to inform our efforts going forward. So some of the legislative and administrative wins, number one is we have diversity provisions that are actually in Covered California. So the goal of Covered California is that it actually reflects the population of California. We are still working on those, but you know, we have those in law. There was also a consumer work group that was established that, again, builds in or bakes in that community engagement piece. And again, we regularly provide review of different notices. Some of the limitations is that, you know, the notices still continue to be very complex, and some of it is just the statutory requirements that the departments have to include certain information in the notices. You know, we continue to work with them. And other limitations is we don't really have funding to do this. This is kind of volunteer things that, people, it's just really important for community members, and so they continue to do it. So the last one I'm going to talk about is consumer-friendly prescription drug labels. So we know the research is out there about covered concerns around the lack of medication adherence. There was a study in California, there was a work group in California. The great thing is that when this information was coming out, we were also advocating or really promoting the fact that for limited English proficient individuals, difficulty understanding your drug label was even more so if you had a language barrier. So state legislation was passed in 2004, I believe, 2006, and then that raised these issues. So it was looking at consumers broadly, but there was a piece in there to really focus on LEP consumers as well. It was a very intense regulatory process. And despite our best efforts at the time, we were not able to get translated prescription drug labels. There were a lot of issues around cost. It was a very political and challenging process. Fast forward 2010, we have the Affordable Care Act. We've done some analysis with our research partners that showed an additional 1.5 million limited English proficient individuals were going to be coming into the system, making the argument that, again, it was really important to look at this issue one more time. And so we proposed legislation to require the translation of prescription drug labels. The Board of Pharmacy at the time had also done some great work around, contracting with researchers, I think including Dr. Michael Wolf, who not just looked at consumer-friendly prescriptions for non-English speakers, but also for English speakers, because this was a problem, this was a literacy issue for everyone. And so the idea was, let's develop some standardized instructions for use, which I will show you here. Take 1 pill at bedtime, take 2 pills at bedtime. Very simple, times of day, the number of pills. And then it would be very easy to translate those into other languages. And they were translated. The board, worked with the California Endowment to provide these translations. They're available in 5 different languages. So our idea was, hey, let's require pharmacies to now use these translations. Our bill did not make it forward, but the issue did not follow. It actually resonated with the Board of Pharmacy at the time, and so they then carried their own bill forward, which was just signed by the governor this year. So going forward, translated prescription drug labels will be required for Spanish, Korean, Chinese, Vietnamese, and not Tagalog, which is actually the 5th language in California. It's actually Russian, because these were based on national numbers. But the first step has been taken around this, and so we look forward to hopefully moving this forward even more so. So I just want to kind of wrap up with some concluding thoughts, which is, as we move forward, one of the key things that we actually face in California is we have some of the standards in place, both on the collection of data and for these language assistance standards. But one of our key problems is on enforcement and making sure that plans are actually doing this. So, where's the hook there to make sure that, we're providing this, that providers understand what their responsibility are, that health plans are complying with these, that even the departments themselves have the resources enough to be able to ensure that these are taking place. And also that we do the evaluation, so that we haven't really, as in the state of California, we haven't looked at or evaluated many of these programs. There was an evaluation done of the translated prescription drug labels that actually showed in some cases for more simple regimens that individuals did understand the translated labels. So also just, kind of looking to better understand what the patient experiences, and this was spoken about earlier too. How can we move beyond, for example, CAPS or other types of consumer, the current system? Is there a way that we can delve a little deeper to understand what the patient experience is, particularly for those, languages that we haven't provided, that don't have the translated surveys? I think wrapped up with all of this is really a look at our healthcare workforce. There's some opportunities here to expand beyond the current models that we have, incorporating promotoras, incorporating community health workers, are really expanding up to the scope of practice and making sure that our workforce really does mirror the patient's needs. And last but not least is to not forget about our community partners, that we don't have to be the experts in all cultures and all language, that there are many different organizations that are there within the community that understand the community's needs, that, as you've seen earlier, can provide some really important insights into the needs of the communities that we're all seeking to serve. So thank you very much, and I look forward to questions.